All right, everyone aiming for that NHS badge, want to make sure you're ready for the MSRA. We're diving deep today into something pretty crucial. Acute coronary syndrome, or ACS, it's a
Yeah.
big one. For the exam, yeah, but way more importantly for those patients you'll be seeing soon.
You're absolutely right. Got to know ACS like the back of your hand, especially here in the UK. It's everywhere, sadly.
Exactly. So we're going to go deeper than just surface level. We're using some top-notch resources, past MSRA.com, that kind of thing. So you walk away with knowledge you can actually use in the real world, Andy, to crush that MSRA.
We're covering the whole 9 yards, different types of ACS, how we manage it here in the UK, all tailored to what you need for that exam.
Love it. So no time to waste. Let's just jump right in. What exactly is acute coronary syndrome anyway?
Great question. It's basically a bunch of conditions, a spectrum where blood flow to the heart suddenly gets restricted. Could be unstable angina, where it's restricted but no actual heart muscle damage, or full-blown heart attacks, your NSTEMI, where they're IS damage.
So it's not just one thing, a whole range. Gotcha. And I've heard they focus on classifying ACS on the MSRA based on like what the ECG shows and troponin levels.
Spot on. You've got STACS, where you see that ST elevation on the ECG, usually bad news, complete blockage, high chance of a STEMI, ST elevation, myocardial infarction.
Sounds scary.
It is. Then there's NSTACS, where you don't see that persistent ST elevation. Might have other changes on the ECG, though. ST depression, T wave inversions could even be normal. That's where the troponin comes in.
Yeah.
If it's a high, you're looking at an STEMI, non-ST elevation myocardial infarction, means there's damage.
So both unstable angina and NSTEMI are under that NST-ACS umbrella, but NSTEMI means something's actually being damaged. And we're focusing on these two mainly today.
Exactly. STEMI's important, don't get me wrong, but unstable angina and NSTEMI, those are the tricky ones, diagnostically speaking.
Okay, makes sense. So what's happening in the body to cause all these different ACS types? It's all about those plaques, right?
You got it. Atherosclerosis, that plaque buildup in the arteries, that's the main problem. Over time, they can rupture, which sets off this whole chain reaction of blood clot forms, blocks the flow to the heart.
Like a time bomb in your arteries. Yikes. I hear stress makes things worse too.
Absolutely. Stress is like the match that lights the fuse. Physical, emotional, doesn't matter. It raises your blood pressure, your heart rate, puts more strain on those plaques, makes them more likely to burst.
Wow, that's a pretty vivid picture. Are some people just more prone to this than others? Like, what are the risk factors we got to keep in mind?
A whole bunch, sadly. Some you can't change. Age, being male, is worse than being a premenopausal woman. And family history, if your parents, siblings had heart issues early, your chances go up.
So some of it's just bad luck, huh? What about the things we can control? What are the modifiable risk factors?
This is where we can make a real difference for our patients. Smoking, obviously, high blood pressure, high cholesterol, diabetes, the usual suspects. Good news is, if you tackle these, you can really drop that ACS risk.
Like having a whole arsenal to fight back.
Exactly. Never too late to start making good choices, quitting smoking, eating better, moving more. It all adds up.
And in the UK, this is a pretty big problem, right? What's the impact on our population?
Massive public health issue, honestly. 2.3 million people dealing with ACS and its aftermath right now in the UK. Leading cause of premature death, takes about 66,000 lives a year. Way too many.
That's a sobering thought. Really puts the spotlight on how important it is to understand and manage this well.
Absolutely. Both for that MSRA and for when you're actually out there practicing. Knowing ACS is essential.
Okay, so we've talked about the types of ACS, what causes it. Let's get a bit more technical for a sec. Talk about pathophysiology. How does this whole thing actually unfold in the body, step by step?
Okay, let's break it down.
Yeah.
It all starts with endothelial dysfunction. Basically, damage to the lining of your blood vessels, like the foundation for all the trouble.
What causes that damage?
Could be lots of things. Smoking, high blood pressure, high cholesterol, diabetes, all contribute. And this damaged lining, it becomes like a magnet for LDL cholesterol, the bad kind. Starts to accumulate in the artery walls, gunks it up.
Yeah, not a pretty picture forming in my mind.
Definitely not. Then this LDL gets oxidized, triggers an inflammatory response. White blood cells, Russian monocytes they're called, and turn into macrophages. These are like little Pac-Man cells that try to eat up the oxidized LDL.
Trying to clean up the mess, right?
They are, but they end up becoming foam cells, these fat-laden cells, and actually make the plaques bigger. It's a vicious cycle. The more they eat, the worse it gets.
Great analogy.
Yeah.
So how do these plaques actually cause ACS?
Well, smooth muscle cells, they come in from the middle layer of the artery, form a cap over the plaque, try to contain it. But these plaques, especially the ones with a thin cap over a big fatty core, those are prone to bursting.
And that's when things really go wrong.
Exactly. Plaque ruptures, the core spills out into the bloodstream, triggers a blood clot, a thrombus. That clot can partially or completely block blood flow to the heart. That's your unstable angina or myocardial infarction.
So it's this whole cascade from that initial damage to the lining all the way to the clot that leads to ACS.
Right, and understanding that whole sequence helps us see just how serious ACS is, why we got to act fast.
So say a patient walks into the ER. What are the red flags? What makes a doctor think ACS right away?
The classic sign is chest pain, often described as crushing, squeezing, like a heavy pressure. Can radiate to the arms, neck, jaw, back even.
Not always the classic clutching the left side of the chest then.
Nope, not always. And that's key, because sometimes it presents differently, especially in older folks, diabetics, certain ethnic groups. Doctors got to be really observant, catch those subtle signs.
Sounds like detective work, huh? What else besides chest pain should raise suspicions?
Could be shortness of breath, sweating, nausea, vomiting, maybe fatigue, even palpitations. But remember, never enough to diagnose based on symptoms alone.
All right, got to do those investigations. But before that, what else can mimic ACS? You mentioned chest pain has tons of causes.
Tons, yeah. Doctors got to think broad, rule things out. Just in the cardiovascular system itself, you've got pericarditis, myocarditis, aortic stenosis, aortic dissection, even a pulmonary embolism.
Wow, that's a lot to keep straight. So eliminating other causes is just as important as confirming ACS itself.
Absolutely. Don't forget about the lungs pneumonia, pneumothorax. Those can cause chest pain too. Then you've got your GI stuff, esophageal spasm, GERD, gastritis, cholecystitis, pancreatitis, all mimicking ACS.
Real diagnostic puzzle then. Anything else we haven't mentioned that can cause chest pain?
Oh, for sure. Don't forget musculoskeletal issues, muscle strains, rib problems. Those often get overlooked, but they can present with chest pain too.
So doctors got to be thinking big picture, considering everything.
Exactly. A thorough history, good exam, then the right investigations. That's how you get to the right answer.
Makes sense. So let's say a doctor, yes, suspecting ACS. What are those key investigations they need to do?
First one, most important, got to get that 12-lead ECG. Tons of information, just a few minutes.
Can really change the game in a suspected ACS case, I bet.
Absolutely. In a STEMI, you'll see those ST segment elevations, and where they are can actually tell you what part of the heart's affected, like a roadmap to the problem.
Okay, that's helpful. What if the ECG doesn't show those ST elevations, though? Does that mean we're in the clear, no ACS?
Not so fast. A normal ECG doesn't rule it out completely, especially early on, or in NSTE ACS. That's where your cardiac enzymes, troponin I and T specifically, are super important. They get released into the blood when heart muscle is damaged.
If troponin's high, that's a sure sign something's wrong.
Pretty much. Even if the ECG doesn't show the classic signs, elevated troponin means injury. And now we have these high-sensitivity troponin tests, so we can catch even tiny amounts of damage, really helpful for early diagnosis.
Wow, that's pretty amazing.
It is. But gotta remember, troponin doesn't peak right away after a heart attack. It takes a few hours. So we do serial blood tests over time to see the trend.
So even if the first one's normal, it could shoot up later.
Exactly. Timing is key.
What other blood tests matter in suspected ACS?
Full blood count, or FBC. That's to check for anemia, which can make things worse. Also gives us a baseline for any anticoagulants we might need to use, part of the management.
Right, got to be careful with those if someone's already at risk of bleeding.
Exactly. Blood glucose is important too. High blood sugars common in ACS can make things worse.
Not just about the heart then. The whole patient picture matters. What about lipids? Do we check those?
For sure. Got to get that lipid profile, see where their cholesterol's at, especially the LDL. That's a big risk factor for atherosclerosis, remember?
Okay, so we've got ECG, troponin, FBC, blood glucose, lipids. Anything else routine for these cases?
Electrolytes and kidney function too. Electrolytes can mess with heart rhythm. And gotta know how the kidneys are doing because some ACS meds can be tough on them.
It's like putting a puzzle together. Each test gives you another piece. Now, aside from blood tests, what about imaging?
Imaging is crucial. We got to see the heart. Echocardiography is super helpful. It's basically using sound waves to get a moving picture of the heart so we can see how well it's pumping if any walls are not moving right because of the ischemia.
So they can see if any parts are struggling because of the lack of blood flow.
Exactly. And it can pick up other issues too, like valve problems.
What about a plain old chest x-ray? Is that still useful?
It can be. Doesn't diagnose ACS directly, but helps us rule out other things that could be causing the chest pain, pneumonia, pneumothorax, heart failure, that kind of thing.
So it helps narrow things down.
Exactly. Then there's coronary angiography, the gold standard for looking at the coronary arteries themselves. We inject a dye, take x-rays, can see any blockages, narrowing, that sort of thing.
Like getting a map of the heart's plumbing.
Great analogy. This is usually the definitive test for coronary artery disease, which is what causes most ACS cases in the first place.
Okay, this is all incredibly helpful. But with all these tests, how do doctors figure out how high risk a patient is? Who needs the most urgent help?
Great question. We call it risk stratification. It's a big part of ACS management. Helps us decide what to do, make sure each patient gets the right care. Here in the UK, we use the GRACE risk score, stands for Global Registry of Acute Cardiac Events.
Tell me more about this GRACE score. What goes into it?
It looks at a bunch of things: age, any previous heart attacks, blood pressure, heart rate, what the ECG shows, troponin levels. All that gets plugged into a formula that calculates their risk of dying within 6 months of an ACS event.
So higher score means higher risk.
Yep. Helps us pick out the people who are in the most danger, need more aggressive treatment.
So with that risk assessment, doctors can tailor the treatment plan.
Exactly. And it's not just about future cardiac events. We also have to think about their bleeding risk, especially with some of the meds we use for ACS.
A delicate balancing act, then.
That's it. Makes managing ACS challenging, but also so important.
Well, we've covered a lot already. Defining ACS, the different types, what causes it, risk factors, even dove into the pathophysiology and all those key investigations.
We've got a good foundation now.
Next up, we're going to tackle how we actually manage ACS here in the UK, what the guidelines say, what you have to know for that MSRA.
Stay tuned for part 2 of our deep dive, where we'll get into management strategies and give you even more knowledge to conquer that MSRA, and more importantly, be amazing doctors for your future patients.
We'll be right back.
Okay, so let's dive into how we actually tackle acute coronary syndrome, especially with that MSRA exam looming.
Yes, because knowing what to DO is just as important as knowing what it is.
Absolutely. And with ACS, time is muscle. We got to act fast, potentially life-saving stuff here.
Every second counts then. Let's break down the management, starting with those first few crucial steps when you suspect ACS.
Okay, so just like any emergency, got to go back to basics. That ABCDE approach: airway, breathing, circulation, disability, exposure.
The good old ABCs. They really come in handy everywhere.
They do. For ACS, making sure there's enough oxygen getting to the heart is vital. So if their oxygen saturation's below 94%, got to give them supplemental oxygen.
Makes sense. Cane relief is a biggie too, I imagine.
Absolutely. We usually start with glyceryl trinitrate, GTN, under the tongue or in the cheek, buccal administration.
I've heard that term, but not sure I could explain it.
Just means between the cheek and gum, basically. Gets absorbed faster that way.
Gotcha. So GTN first, then what?
If the pain's really bad, or we think it's an MI, might need intravenous opioids, morphine usually.
And aspirin's a must in ACS, right?
Absolutely. 300 milligrams, loading dose, as soon as possible unless they're allergic. Aspirin stops those platelets from sticking together, helps prevent more clots.
So that's the initial attack plan. What happens next? Does it change depending on what kind of ACS it is?
Big time, yeah. The next steps are different for STEMI, NSTEMI, unstable angina. Let's start with STEMI. That's usually the most urgent.
Okay, STEMI, the one with the ST elevation on the ECG. What's the absolute priority there?
Reperfusion therapy. Got to restore blood flow to that blocked artery fast. Open up those pipes, get that heart muscle the oxygen it's screaming for.
Sounds intense.
It is. We've got 2 main ways to do this: primary percutaneous coronary intervention, PCI, and fibrinolysis.
Break those down for me.
Sure. PCI, sometimes called angioplasty, it's basically like plumbing for the heart. We thread a catheter into the blocked artery, use a tiny balloon to open it up, often put in a stent too, little metal mesh tube, keeps it open long term.
Like scaffolding for the artery.
Exactly. Now, fibrinolysis, that's different. It's a medication. We give it intravenously, dissolves the clot. So PCI is mechanical, fibrinolysis is chemical.
Okay, seeing the difference. How do doctors decide which one to use?
Depends on a few things: whether PCI is available, how long it's been since the symptoms started, the patient's overall condition.
So if someone comes in with a STEMI, every minute counts to get them the right treatment.
Absolutely. Time is muscle. Can't say it enough. The longer that blockage is there, the more damage to the heart.
Wow, powerful reminder. Any other meds besides reperfusion therapy and STEMI?
Yes, dual antiplatelet therapy is essential. We give them 2 different kinds of antiplatelet meds to really clamp down on that clotting.
So aspirin plus something else.
Right, usually aspirin plus either clopidogrel, prasugrel, or ticagrelor, or depends on a few things, their bleeding risk, that sort of thing.
So they're getting these meds at the same time as the reperfusion therapy.
Yep, usually start them ASAP, continue for a while after the procedure too.
Okay, that makes sense. Now, what about NSTEMI and unstable angina? Different approach than STEMI.
It is, yeah. We use that GRACE score we talked about to guide us. If they're low risk, GRACE score 3% or less, we might manage them conservatively. No immediate angiography.
So no rush to the cath lab.
Not necessarily, but even low risk, we still do dual antiplatelet therapy, usually aspirin plus either ticagrelor or clopidogrel.
So even without the angiography right away, they're still getting meds to prevent more clotting.
Exactly. Now, if they're high risk, GRACE score above 3%, then we usually recommend early angiography.
To see how bad the blockage is, if they need PCI.
Exactly. And if we find a blockage that's suitable for PCI, we can often do it right then, during the same procedure.
Efficient. You mentioned antithrombin therapy before. Does that come into play for NSTEMI and unstable angina too?
It does. Medications like fondaparinux or heparin, they also help prevent clotting, often given alongside the antiplatelet therapy.
Multi-pronged attack on those clots.
That's the idea. And which antithrombin we use, how long, it all depends on the patient and their individual risk factors.
Okay, so we've covered the initial management for all 3 types. What about long-term? What do we do to prevent future problems?
That's secondary prevention, all about reducing the risk of more heart attacks, strokes, any cardiovascular issues down the line, not just treating the immediate problem, preventing the next one.
A long-term strategy then. What are the main components of that?
It's a combination, lifestyle changes and medication.
Let's start with lifestyle. What do we recommend for ACS patients?
Pretty much the same as for anyone wanting a healthier heart. Quit smoking, healthy diet, regular exercise, manage stress.
Good advice for all of us, really.
It is, but for someone who's already had an ACS event, it's even more crucial.
Makes sense. Aside from lifestyle, what meds are usually prescribed?
A few key ones. ACE inhibitors like ramipril or lisinopril. They lower blood pressure, reduce the workload on the heart, like a shield for the heart.
Nice image. What else?
Beta blockers, they lower blood pressure too and slow down the heart rate, like giving the heart a little vacation.
Yeah.
Bisoprolol, metoprolol, those are common ones.
I like that analogy. And statins, gotta have those.
Absolutely. Statins, like atorvastatin or simvastatin, they lower cholesterol, which reduces that plaque buildup in the arteries, addressing the root cause.
Essential for long-term prevention then. Anything else commonly used?
Aspirin usually gets continued indefinitely for secondary prevention, so those lifestyle changes plus those 4 medications, that's the cornerstone.
Sounds like the doctor and patient really have to work together here.
Definitely.
Yeah.
And speaking of teamwork, cardiac rehab programs are a big part of secondary prevention too.
I've heard of those, but not really sure what they involve.
They're usually multidisciplinary, nurses, physios, dietitians, psychologists, all involved. Really holistic approach.
So it's more than just pills. It's about supporting the whole patient.
Exactly. They help them regain strength, stamina through supervised exercise, education about heart-healthy living, emotional support.
Sounds like a great resource.
It is. Studies show it can really improve quality of life, reduce the risk of future events.
That's fantastic. So we've gone from the initial emergency all the way to long-term care. I'm curious, what about the prognosis for these patients? What determines how well they'll do long-term?
That's a great question. Prognosis for ACS patients, it can vary a lot, and lots of things play into it.
Like what?
One of the biggest is how much heart muscle was damaged. The more damage, the higher the risk of complications, long-term problems.
That's why early diagnosis and treatment are so vital.
Absolutely. Comorbidities matter too. Other health issues, diabetes, kidney disease, those complicate things.
So it's not just about the heart itself, but the whole patient's health.
Exactly. And of course, age and their general health play a role too.
So it's very individual then.
It is. But the good news is, with quick treatment, lifestyle changes, and sticking to their meds, a lot of ACS patients can go on to live long, healthy lives.
That's encouraging to hear. But what about complications? What are some things doctors need to be on the lookout for?
One of the most serious is heart failure, where the heart can't pump effectively anymore.
That's when it can't pump enough blood.
Right. And if it's really bad, can lead to cardiogenic shock. That's life-threatening. The heart's just not pumping enough to meet the body's needs.
That sounds terrifying.
It is. Arrhythmias are another potential complication, irregular heart rhythms. Those can range from not so bad to really dangerous. Close monitoring's key.
What about complications specifically from the heart attack itself?
There are some rarer ones, but they can be devastating. Ventricular rupture, that's where a hole forms in the heart wall, and ischemic mitral regurgitation, where the mitral valve, one of the heart's valves, starts leaking because of damage from the heart attack.
These complications sound so complex.
They can be, and managing them well, it takes real cardiology expertise.
Okay, so we've covered a lot about ACS management, from the first response to long-term care and those potential complications. Before we move on, just a quick question. We've talked a lot about the GRACE risk score. Are there other scoring systems used in the UK for ACS?
The GRACE score is usually the go-to here, but there's also the TEAM risk score, stands for thrombolysis in myocardial infarction. It's older than GRACE, but some doctors still use it, especially when we're talking about fibrinolytic therapy.
Okay, good to know. Now, I think our listeners are probably wondering how all this applies to the MSRA exam.
Great point. Let's shift gears a bit and see how all this knowledge can help you tackle those MSRA questions.
Perfect. Let's put it all together and see if we can ace those SBAs. All right, so we've talked a lot about acute coronary syndrome, how to recognize it, how to manage it. But there's one area that I think trips a lot of people up on the MSRA, and honestly, even in real life, those ECG changes.
Yeah, ECG interpretation can be tricky, but it's essential. Got to be able to decipher those squiggly lines to manage ACS effectively.
Exactly. So let's break it down. I know the ECG tells us what part of the heart's affected, but how?
Okay, so each coronary artery, it supplies blood to a specific area of the heart, right? When one gets blocked, the electrical activity in that area, it goes haywire.
So the ECG is picking up on those electrical disruptions.
Exactly. And where those changes show up on the ECG, that corresponds to the area that's not getting enough blood.
So can you give us some examples, specific ECG changes and what they tell us about the artery involved?
Sure. Let's start with the anterior wall that's mainly supplied by the left anterior descending artery, the LAD. You might have heard it called the widowmaker, kind of grim, but blockages there can be really bad news.
Yeah, that's a name that sticks with you. So what would we see on the ECG in an anterior STEMI?
Typically, you'd see ST segment elevation in leads V1 to V4. Those leads, they give us a view of the front of the heart where the LAD is doing its job.
So ST elevation in those leads, big red flag for a LAD blockage.
You got it. Now let's move to the inferior wall. That's mainly supplied by the right coronary artery, the RCA.
We talked about inferior STEMAs earlier. What do those look like on the ECG?
For an inferior STEMI, you'd usually see ST elevation in leads 2, 3, and AVF. Those are the leads that look at the bottom of the heart.
Okay, so ST elevation there points to an RCA blockage. What about the lateral wall?
Lateral wall, that's the left circumflex artery, the LCX. Blockage there, you'd see ST elevation in leads I, AVL, V5, and V6.
So each set of leads corresponds to a different part of the heart, and by looking at the changes, we can figure out which artery is involved.
Exactly. It's like a map. The ECG is showing us the heart's electrical system. We just got to know how to read it.
Right.
Of course, it's not always as clear-cut. There can be variations.
Right, real life is always more complicated than the textbooks.
It is. Experience is key for ECG interpretation. But knowing these basic principles, that's a great place to start.
This is super helpful. Now let's talk about the medications we use in ACS. We touched on some earlier, but it'd be good to dive a bit deeper. How do they actually work? What side effects do we need to keep in mind?
Definitely. Let's start with aspirin. Seems like a simple drug, but it's a real workhorse in ACS.
I've always wondered, how does it actually help in this situation?
Well, aspirin's an antiplatelet medication, meaning it stops platelets from forming clots. And clots, those are the bad guys in ACS, blocking the blood flow.
Right. Got to stop them somehow.
Aspirin blocks an enzyme called cyclooxygenase, COX, which is involved in making thromboxane A2, and that's a substance that makes platelets clump together.
So it basically sabotages the clotting process.
Pretty much. That's why we give that loading dose of aspirin ASCP in suspected ACS.
What about those other antiplatelet agents? Clopidogrel, prasugrel, ticagrelor, those guys. How are they different from aspirin?
So aspirin works on that COX pathway. These other ones target something called the P2Y12 receptor. It's involved in another part of how platelets get activated.
Like a double whammy then, hitting the clotting process from two sides.
Exactly. That's why we often use dual antiplatelet therapy, aspirin plus one of these P2Y12 inhibitors, for more complete protection.
Okay, that makes sense. What about side effects? Anything we need to be cautious about?
The main concern with all these antiplatelet drugs is bleeding. They're thinning the blood, so bruising, bleeding longer from cuts, even more serious bleeding events can happen.
So it's about finding that balance, preventing clots, but also managing that bleeding risk.
Exactly. Gotta assess each patient's individual risk carefully. Now, let's switch gears to antithrombin medications like fondaparinux and heparin.
Oh yeah, we talked about this earlier. They also prevent clots, right?
They do, but they work differently than the antiplatelet drugs. They go after thrombin, which is a key enzyme in the coagulation cascade, the whole chain reaction that leads to clotting.
So antiplatelets are all about the platelets.
Yeah.
Antithrombins are all about thrombin.
Exactly. Tackling different parts of the process.
What about their side effects?
Similar to antiplatelets, bleeding's the main concern. Heparin specifically, there's a rare but serious complication called heparin-induced thrombocytopenia, or HIT.
That sounds pretty bad.
It is. It's an immune reaction to the heparin, can actually cause more clotting, the opposite of what we want.
Just got to be on the lookout for that. Monitor patients closely.
Absolutely. Now, besides those, we've also got beta blockers, ACE inhibitors, statins, all part of the ACS management picture.
Right, those were part of the secondary prevention strategy.
Yeah.
Can you remind us how those work and why they're important?
Sure. Beta blockers like bisoprolol or metoprolol, they block the effects of adrenaline on the heart. So they lower heart rate, lower blood pressure, basically ease the strain on the heart.
Giving the heart a little break.
Exactly. ACE inhibitors like ramipril or lisinopril, they block the production of angiotensin II. That's a hormone that makes blood vessels constrict. So again, lowering blood pressure, less strain on the heart.
Helping those blood vessels relax. And statins.
Statins, like atorvastatin or simvastatin, they lower LDL cholesterol by blocking an enzyme involved in cholesterol production. Helps stop those plaques from building up in the arteries.
So they're working on the root cause, long-term prevention.
Exactly. It's amazing. Each of these medications has its own specific role to play in managing ACS. Now, before we wrap up, I'm wondering about the prognosis for ACS patients. What makes someone more likely to have a bad outcome?
That's an important question. There are a few things. Age is a big one. The older you are, the harder it is for your body and your heart to bounce back.
Makes sense. What else?
The severity of those ECG changes we talked about. The bigger those ST deviations, the more likely there's significant damage. And that usually means a worse prognosis.
Those ECG patterns, they really do tell a story.
They do. And troponin levels, how high they are, that's also a key factor. The higher the troponin, the more damage, which usually means a worse outcome.
It's not just whether it's elevated, it's how elevated it is.
Right. Another red flag is left ventricular dysfunction. That's when the heart's main pumping chamber isn't working properly. We can see that on echocardiography.
Those imaging studies are helpful for prognosis too, yeah.
And then there are complications. If those develop, that can really change things for the worse. Cardiogenic shock, serious arrhythmias, kidney problems, uncontrolled diabetes, anemia, those all increase the risk of a bad outcome.
It's a lot to consider when you're trying to figure out a patient's prognosis.
It is. But the goal is always to minimize those complications, give our patients the best chance to recover fully.
Absolutely.
Well, this has been an amazing deep dive into acute coronary syndrome. We covered so much, what it is, what causes it, how we diagnose it, how we manage it, even got into those ECG changes and all those important medications.
We really hit all the key points, both for the MSRA and for when you're actually out there practicing.
And speaking of the MSRA, don't forget about pathophysiology.com. Fantastic resource specifically for the exam. Practice questions, explanations, lots of helpful tips.
Definitely check it out. Great way to solidify your knowledge, build your confidence.
To all our listeners out there, good luck with your MSRA prep. You got this. We'll be back soon with another deep dive, something else to help you be the best doctors you can be.
Until next time, keep learning, keep those brains sharp.
See y'all soon.